Welcome to Knowledge on the Go, the podcast where we dive deeper into the topics we explore on our PI Collaboratives webcasts. I'm your host, Marilyn Sherrill. On this episode, we'll find out how Lehigh Valley Health Network used data to fuel their program that manages the use of opioids in orthopedic procedures.
I am on a quality committee here for one of our local insurers, and there's a meeting that happens at like 7 o'clock in the morning once every 3 months, and it's about 90 miles from where I live. On the way home that day, I was listening to a podcast.
Dr. Matt McCambridge is the Chief Quality and Patient Safety Officer at Lehigh Valley Health Network. The podcast he listened to that day would lead him to undertake a brand new initiative at his organization.
So Tom Lee does this interview series called Good Doctors, and he was interviewing a doctor named Michael Anglesby. And Michael Anglesby is a trauma surgeon who works in the state of Michigan. And it was a really captivating podcast about how Dr. Anglesby in one weekend, not only does he place organs in, but unfortunately he harvests organs as well. And he was really moved one weekend when he was harvesting the organs of a number of young people who had overdosed from opioids. So listening to this podcast, driving back across the state of Pennsylvania, and I sat down and found Josh when I got back. We got talking about how are we doing regarding opioid prescribing. Josh had already done a lot of work in that area.
We decided to begin working on this project, and I believe everything just kind of came together perfectly because at that same time, Vizient had come out with a collaborative to reduce opioid prescribing in orthopedics.
Josh Rosentel is the Clinical Quality Information Analyst with the Quality Department at Lehigh Valley Health Network. He is both a data analyst and clinical quality specialist, and he joined Dr. McCambridge in their new initiative.
We have an excellent opioid stewardship committee here, and this is a lot of work that they have been doing for a long period of time. They have a multi-pronged approach. They try to prevent new SUD, reduce stigma, and treat existing substance use disorder in our community.
Pennsylvania is like many of the states around the United States. So we had seen a lot of overdose deaths over the last several years. So we began work on appropriate opioid utilization and prescribing. And what we could see both in the ambulatory setting and in the inpatient setting was a reasonable amount of variation among the providers. That was kind of our initial push is when we started looking at seeing the variation, we knew we had a lot of opportunities.
Dr. McCambridge and Josh saw right away that their efforts had to start with data they could show to providers, and the data had to be accurate.
The thing about physicians that's interesting is many of them are inherently quite good at math. So the data has to be good. When you're sitting in front of a physician or a group of physicians, their mind goes very quickly to whether the data is accurate or not. So Josh and I spent a lot of time figuring out whether the data is accurate or not. Then when you're talking to a bunch of orthopedic surgeons, they're very, very busy people. And you get maybe 5 or 10 minutes during breakfast right before their day starts. Josh and I will spend a couple weeks looking at the data, and then we'll prepare one slide. How much opioids are the patient being prescribed, and how much are they actually taking at home? And pulling that down on one slide and then showing them what that looks like.
Sometimes the information on that slide was a big surprise.
We had one provider who felt that their prescribing was lower compared to their peers for the exact same population of patients. When we were able to pull the data out of the system and show it to this specific provider, it turned out that their prescribing was actually one of the highest amongst the group of providers that were discharging these patients. The data kind of painted a different picture and was able to help this provider in making future decisions when discharging patients. The providers that I have worked with and the nurses that I have worked with, they want nothing more than to provide the best care to their patients. So when we find data that kind of paints a different picture, we really need to be cautious in how we approach discussing this with these particular providers and these nurses. There is so much data available, but when you are able to construct it right and really tell a story with it, we can really get our point across to the providers. And I think that my experience through nursing, through IS, and now into the quality department has really helped me to be able to lead those quality improvement projects.
Besides showing a slide to each physician or clinician to display relevant data around their clinical practice, Dr. McCambridge and Josh also provided comparative data showing how each physician and clinician fared against their peers. They were careful not to be punitive.
Some of them are totally cool with having totally transparent data. For instance, maybe if you're standing in front of a bunch of surgeons, when you're talking about opioids, they're cool with having everybody's names down there below where their individual data are and showing them all together just in a room. But other groups may be not so receptive to that. But then in private, we'll send the graph out again and we'll number them A through H, which Josh does. And we'll go back to the provider and say, just want to let you know your letter like you would, C. So it lets them know how they're doing against their peers.
One other thing that I have found in my experience is to remind providers when we go and discuss with them that we're looking to improve the process. We want them to come back to us and say, we think that this is the problem, or we think that some changes can be made here to improve the process. And that is always really helpful, I think, in making people feel like we are not being punitive, we are not coming after them, but rather we are looking for them to help us in how we can improve the current situation.
With their program successfully underway with orthopedic procedures, Dr. McCambridge and Josh started to spread their approach to other areas.
When we saw the opioid data, we worked on that for a good solid year, working with the APCs, APPs, and the docs to get their prescribing down. And then fairly quickly, Josh started showing data and seeing data in other areas. So, for instance, general surgery and laparoscopic cholecystectomy, appendectomies, and then cardiothoracic surgery.
Interestingly, when we spoke to the cardiothoracic surgeons about the CABG, they were eager to help out, and they asked that we kind of look at all of their patients. They felt, why just look at CABG patients? Let's look at the valve replacements and the other patients that we're doing as well, which was fantastic to hear from them that they just want to expand the project.
The successful use of data to change practice at Lehigh Valley required more than what the EMR alone could provide. That's where Vizient's clinical database, or CDB, came into play. Josh and Dr. McCambridge explain.
We noticed an issue with our readmissions, hospital-wide readmissions. The CDB has allowed us to essentially slice and dice our readmissions at a number of levels. We can look at specific MSDRGs where maybe we can make some difference in those 30-day or 7-day readmissions. We can look at the Vizient service lines or sub-service lines, and then we can compare ourselves, right? We could benchmark ourselves against all of these other hospitals and be able to say, oh, you know what, we have an issue here with readmissions, and maybe this would be the best place to focus, and maybe that will help to make an overall reduction in the hospital-wide readmission rate.
The CDB and the CRM to us have been absolutely invaluable. We'll see a signal in our own internal data, and then we'll go pretty quickly to the CDB and the CRM and benchmark ourselves and see kind of how we're doing and see if it's true, something we have to work on. For the chief quality officers out there, you really have to get under the hood. You have to learn how to use the CDB yourself so that you can have intelligent conversations with people like Josh. You know, if you're seeing these big utilization categories in the CRM, you can identify those. And then not only are you decreasing utilization and avoiding waste, but you can then identify topics. And it's really, really important as a CQO that now I have a more than a rudimentary understanding of the CDB and how to pull my own reports. And then I go to people like Josh who are so much more facile with it. And then you can really take off from there.
In summary, Matt had a final thought to leave with us.
I think it's important for all healthcare providers around the country to have a feel for how they're doing regarding opioid prescribing. And our experience here has been, if the data is good, the providers have been real receptive to that kind of feedback. We don't do much without some type of pretty solid data that informs our quality projects. You know, without data, you're just another guy with an opinion.
That's all the time we have for this edition of Knowledge on the Go. I want to thank Dr. Matt McCambridge and Josh Rosentel for joining us on this podcast. And thanks to you, our listeners, for taking the time to join in as well. And please look for our future Knowledge on the Go podcasts. For Vizient, I'm Marilyn Sherrill. Thanks again for listening.